Hello everyone, and welcome to Conversations Interpreting and Translating Healthcare Specialty Series webinar, Understanding Pain. Today's webinar is being presented by osteopath Dr. Amy Lawton, and this is the third part in our series of webinars with Amy. And in this webinar, she's going to be focusing on the nervous system and understanding pain. Now, before we start, just a little bit of housekeeping as usual. The webinar duration tonight is 90 minutes and the webinar is being recorded. Those of you that have registered will be emailed with a link to the video tomorrow, so you can access that whatever you like. You can either use it for future PD, or if there's anything that you want to do some recap on, you can always go back and watch it. Now, those of you that are attending live today, you will be sent out a certificate of attendance. And this will be reaching you within a week or so, so please be patient. Those that have registered for the live webinar and attend for the full duration of the webinar will be issued with the certificate. Okay, so you got to register, come and watch the whole thing, and then within a week or so, expect a certificate in your email. The webinar is an interactive webinar, so if you have any comments and questions, please put them into the GoToWebinar question part you can see on your screen, and you can put comments in there, ask questions in there, and we'll try to answer as many as we can. We're going to have some questions asked by Amy throughout as well, so if you would like to participate, please, you can put your answers in there too. As usual, there's a few handouts for you to download from the GoToWebinar app. You will have the slides to today's presentation. You will also have a glossary of terms as well as a reference and useful link list as well you can download. And my personal favorite, as usual, you have the AUSIT Code of Ethics there. If you haven't downloaded it from anywhere this week, let today be the day it is. So Code of Ethics there for you as well. Before I go on too much longer, I'd like to hand it over to Dr. Amy for tonight's presentation. Thank you very much, Amy.
Great. Thanks, Fatih. Welcome, everybody. It's nice to see or to have you back again for those who are joining for the third part today. So, as Fatih has said, today we'll be focusing on pain, thinking about what it is and, importantly, what it isn't, and breaking down some common misconceptions. We'll have a look at the anatomy and physiology behind pain and what happens in chronic pain conditions as well, and then have a chat about the treatment and management. As Fatih said, please let me know if you've got any questions. We do have some kind of trickier concepts today, so yeah, the more you're wondering about something that hasn't quite made sense, or there's something else you'd like to know, chances are that someone else has the same question, so please chime in with those. Just a recap about me for anyone who hasn't been at the other webinars that we've done. So my name's Amy, I'm an osteopath. I started my studies at Melbourne University and did a Bachelor of Science where I had a real interest in neurology and physiology, hence today's webinar. I then went on to Victoria University, and I got my Bachelor and Master's degrees for osteopathy, and I went on to do my graduate certificate in tertiary education as well, which means that I now treat at a couple of clinics and I work at Vic Uni as an academic there. All right, so just a reminder that any information that I give today, it's not intended for the purpose of providing any medical advice. If you do have any questions that are specific to a condition or your personal situation, please consult a qualified doctor or healthcare provider for that. Okay, so firstly, why is it important to understand pain? Firstly, I guess specific to this audience is because you'll be interpreting for people who are in pain, and that will really help them if you can understand what you're interpreting. But most importantly, pain is amazing, and it's really protects us. It's a normal part of life. For those, there are some conditions where people are born without the ability to actually feel pain, and they don't unfortunately actually survive very long, and that's because they're not getting that communication about danger or threat to their safety, so they don't react appropriately to that. So it's a really important part of being alive. And if we understand it, like with most things, if we understand it, we're less fearful of it, and then we can give it an appropriate reaction when we do feel it. And you'll probably find this a little bit as we go through, that the reality of pain as a physiological process goes against what many people, including myself before I've learnt about it, it goes against what we believe and what advertising and kind of, I guess, what society outside of the scientific realm tells us. And it's a really emerging area where over the last, say, 15, 20 years, our understanding of pain has just increased dramatically. And there's so much research being done into this area, and we've really shifted our understanding of it, even within science and within healthcare. And now it's kind of time for that to trickle down into everybody else. So we really have a good understanding of what pain represents and how to best deal with it. And most importantly, not to be fearful of it, because as I said, it is an amazing protector. So if we have a look at this definition of pain, so this comes from the International Association for the Study of Pain. So the definition: an unpleasant sensory and emotional experience associated with or resembling actual or potential tissue damage. So this is a new definition as of 2020. As I said, our understanding of pain is really updating very rapidly. So let's break this down a little bit. So it's an unpleasant sensory experience. So we all know that pain is unpleasant. It's unpleasant for a reason, because it's representing danger. So if we're in danger, we want to feel that. If we're in danger and it's appropriate, then we want to feel that pain strongly to get us to react. The important part here is that it's also an emotional experience. So something can not feel nice, but if we don't have that emotional experience, we usually don't class that as actually being pain. So if we think about some of the feelings that you might have, maybe if we think about muscles a little bit, so muscular tightness, we wouldn't usually describe that as pain. Most people say, my muscles, I feel like I'm really tight through my muscles. And that is just another step on this continuum of what you're feeling. So if it's not at the point where you're in enough apparent danger that you want to have that emotional experience, you'll still get a sensation, but you don't have that emotional reaction. And it's once we start layering on that emotional reaction that it really becomes pain. And then it says here, actual or potential tissue damage. And this is going to be really important, and we will come back to it as we go. We can have pain with tissue damage. We can have pain without there being any tissue damage, and the other way around. We have tissue damage and we feel pain. We can also have tissue damage and we don't feel any pain. So keep that in mind, and we're going to come back to it with some examples later, and that's going to be one of the things that'll really get you to think about. And later on, when I ask if you've got an example that you'd like to give of a time when you had pain without there actually being injury or another condition associated with it, or the opposite way around, there was an injury or a condition and you would have expected to feel pain but you didn't, we can use those as really good examples to try and cement some of these concepts. There's these 6 associated keynotes that come through with the definition of pain, and this just really represents that pain is complex. With all of this layering, even just through, we need to think about whether tissue damage is present or not. We're adding on emotional factors. You can see even at that really base level, it is quite complicated. So we just need some additional statements to support that definition that we've just been through. So pain is always a personal experience. It's different for everybody. 2 people can have seemingly the exact same injury and feel very differing amounts of pain. And that's because it's affected by biological, psychological, and social factors. And we'll chat a bit more about that later. In fact, all of these we'll cover as we go along. We'll look at the difference between pain and nociception, and that will make more sense later on. Through our life experiences, we learn the concept of pain. So when we're very young, if you think about as a child, they can fall over and have really nothing coming up there. You look at and think that, oh gosh, they're really going to have cut open their knee or something, and then you look and there's nothing there, but they're crying and they're telling you it's really sore. And then you distract them slightly and all of a sudden the knee's forgotten about and they're running around and doing everything that they were. So through all of these experiences from when we're very young and through TV, through advertising about pain, through what our parents or our family tell us about it, through to cultural norms around pain. This is how we learn what pain means and how we should respond to it. And whilst that can be helpful in some ways, it's still only helpful as far as if you actually understand what pain means. Otherwise, we can put a whole lot of layers onto it that aren't particularly helpful. So a person's report of an experience of pain should be respected. And that's really important when it comes to healthcare, that pain is always real. It's not in someone's head, even though we will see that the brain really controls everything. And we always need to respect that. So pain has an adaptive role. As we've already said, it's there for protection, but it can have adverse effects on function and our social and psychological well-being. So if pain is stopping us from physically functioning, but also being able to engage socially, and then of course, pain feels horrible and it can really have psychological impact. And verbal description is one way that will express pain, but just because we can't express that, it doesn't mean that pain doesn't exist. All right, so as I said, we'll come back to those as we go, but please let Fatih know if you've got any questions so far. Good. All right, so what we've got sorry?
All good.
What we've got so far. Pain is an unpleasant feeling, we all know that. It compels us to consciously protect that area. So if our brain thinks that a part of our body is in danger and it needs protecting, then our brain will give us the sensation of pain, so we protect it. We have some other protective mechanisms. So movement. So if you ever think about that, we spoke about a reflex last time. If you go to put your finger on something hot or something sharp, we get a really sudden reflex movement. But then if you also think about, say, if you've got a sore knee or a sore ankle, the way that we move differently, the way we walk, stand, sit differently to try and protect that area. Our immune system also has a big role in protecting us. Our thoughts will protect us. So, you can hopefully think, oh, my ankle's sore and I'm not going to jump up and down before you jump and then have to protect the area with a different movement. Our hormones work really closely with the immune system, and then our autonomic nervous system. So you might have heard of we have the sympathetic and parasympathetic nervous systems. So our sympathetic nervous system is the fight or flight system. So when we need to really release a lot of, say, like adrenaline and run away from something or turn to fight. So it's quite a primitive response in some ways, but that can also just be if you're nervous before giving a presentation or something along those lines and you get those butterflies in your tummy. That's all of the sympathetic nervous system, and that's half of the autonomic. Whereas then we have our parasympathetic nervous system, which is called our rest and digest system. So that's the one, exactly as it says, when we're resting or when we're digesting food and we're going through those daily functions, that one will kick in. So those two systems are there to really protect us. So either to allow us to fight or flee or to rest and digest. Pain is modulated or changed by any credible evidence that protection is or isn't needed. We're going to come back to that one a lot. And pain does not predict the amount of tissue damage that is present. So, the brain. To understand pain, we really need to understand the brain first, because the brain controls everything. The interesting thing is that our brain is protected inside our really strong skull. So then how does it do that? Because it's got the skull surrounding it, so it can't directly interact with our environment. And it also, doesn't directly it's got connections through other systems, say through to our toe, but it doesn't it can't just see what's happening there. So it really relies on all of our sensory organs to send it information. Then it can make a decision on how to keep us alive and well at that stage. So it's constantly receiving and processing and sending information. So let's use vision as an example to try and nut this out a little bit. So vision, light enters our eyes. So you can see in the diagram that's at the top part of it. And we have a left and right visual field. So your right visually, if you imagine those, like if you cover one eye and the other, that's your visual fields for left and right. So that light enters your eyes. The retina, which is right at the back of the eye, you'll see that marked on the diagram. That's where the nerve cells that are stimulated by the light live. So the messages from the retina are then sent along our optic nerves, and we have a left and a right one happening all the way through this, back to the brain. So it's only at that stage. So far, all it's been is light hitting the eye and then nervous system sending electrical impulses along the nerves. So those electrical impulses at that stage are the same as any other electrical impulses through the nerves in our body. It's once that those impulses reach the brain that the brain starts to put all of that information together. So that area of the brain is specialized. So it's at the back of your head in the occipital area, just if anyone's interested in some other words. That area of the brain is specialized to interpret those signals coming from the eyes. So it interprets it, and then we don't see things as right and left. So our brain actually has to combine all of that information together, so we just see one image. The interesting thing is that what we see really depends on what our brain chooses to pay attention to. And we can demonstrate this with some visual illusions, which you may have seen some of these before. So if we look at this one first, take a look and quickly type into the chat, tell me what you see in that picture.
So what do you see in that picture? Type it in. Sorry, Amy, I cut you off.
Yeah, that's okay. So yeah, type that in, and then if you can see more than one thing.
Two faces. I've got one interpreter, two faces. Just depends.
Can anyone see something differently? What can you see, Fatih?
A vase in the middle, shade, two faces, wine glass.
Wine glass, nice. I hope that person has a glass of wine at the moment.
I definitely also see a wine glass at this time of the night.
Great. So depending on how you focus your eyes, and I'll give everyone a chance to have a go at this, just to kind of squint your eyes and then open them wide, look a little bit to the left and right as you do that, and you should be able to see that, yeah, depending on the way that you look at it, you can either see a vase or a candlestick or a wine glass. They're all very valid responses, or you might see two faces looking at each other. And again, that's just going by what your brain is deciding to pay attention to at that moment. Nothing's changed in the picture. We've got this one as well. Again, if we can get some answers about what you see in this picture.
Amy, I tried this one earlier. I can only see one. Everything else I can't see the other one.
I'll tell you the trick in a moment.
Okay, and this one, a lady is one of the answers. I see two faces and the base intermittently. Maybe that's for the previous one. Elderly woman.
Yep.
I can see like a lady facing away from us with a beautiful headpiece.
Nice. But and then, so if you take your vision, if you can see the younger lady looking away, and you're looking at her chin, look downwards to her neck or to
wow, it's an old lady.
Chest.
Oh wow.
Yeah, and then you see the older lady. So once again, the picture hasn't actually changed, but what you've done then is just changed your focus slightly, so your brain is paying attention to a slightly different point on the picture. and you see something totally different. If you look partway in between at the black around where the old lady's mouth is, or the older lady's mouth is, people like, then you can kind of toggle between the two quite easily. You can almost hold both of them in your brain or in your sight at the same time.
Yep, I've just been freaked out right now.
Yeah.
I tried all afternoon to see the second one. I couldn't see it.
There we go. Just got to know the trick. Good. And then ones like this. So someone's drawn this. We know that that's a flat piece of paper and that's been drawn on. We know that in our mind, yet if we don't think about that and we really look down that hole, we easily think that that's 3D. But if you bring your vision back a bit and then you look at the outsides of it, then you like convince yourself, or not convince yourself, you recognize more that it is a piece of paper that someone's drawn on. So I've got that one. And the last one, can anyone see what's kind of wrong about this picture when you first look at it? So what's the issue with, we're looking at the inside of a mask there. What's the problem though?
It's scary.
Yeah, and there's a reason why it seems creepy. The reason is what we're trying to get to. So I'll be interested to know if anyone can see it. And there is, if you look up this one on YouTube, you can see the mask actually rotating around, which is another interesting way of looking at it.
Even creepier.
Yes. Don't do it just before bed.
Yes, so just waiting on some responses there. It does take a little longer for the text to come through. So
that's all right.
We can see inside of the mask.
Yep.
The nose is outside the inside, Magdalena said.
That's it.
Inside,
perfect.
The side is pulled out the front. Yeah.
Yep. The nose is facing towards us instead of facing away from us. And when you look at it, when you have like this one, it's a bit harder just to squint and kind of see it. I really recommend you look up the turning one and you really see that you can change the way that your brain pays attention to the nose. So you can actually, really change your perspective on it. But it does take you a moment, you look at it and you think, oh yeah, normal face, but there's something wrong about it. You can't quite place what it is. And it's only once you really focus your attention and think, okay, why does this not seem right, that you realize that it's actually pointing in towards you instead of pointing away like it should be. So all of these are here just to demonstrate that it's really the things that we sense and the things that we feel are always based on what we're paying attention to at the time. And pain is no different to that. So when we think about how the brain knows how to interpret the information it receives, so our only real tool for answering this question is past experience. So what did it mean the last time that I received similar information? So it's really what we just went through with the mask, is comparing that past experience to what I'm seeing now. How does it differ and why does this not look right? You've just been through that exact process, but very consciously, whereas subconsciously, this is always happening in everything that we want to do. So our brain is actually governed by it predicting and then correcting. So it's not governed by stimulus and response. So if you think about, if you want to reach out to your glass of water or wine, whatever you've got, then as you go to reach for it, your brain looks at how far away that is and the position that it's in. It thinks, okay, I've reached in that direction before, I can judge that. Now, sometimes you won't do that very smoothly, or you'll catch your hand or knock it over, whatever it might be. That's because your brain has predicted what it needed to do, but it hasn't quite gotten it right. So then it will try and correct your movement. Whereas if we're just always waiting for a stimulus and responding, that's a really inefficient way for our body to work. And it's not the way of working with prediction and then correction is actually really adaptive. that allows us to learn from the mistakes. If we're always just waiting for a stimulus and then getting a response without the prediction part of it, it's not an efficient way to learn at all. And this is all applying to both internal and external information. So as I just gave the example of when you look at something and you want to pick it up, but this is also happening inside our body, say for digesting food. If you've just had dinner, then the way that our body is receiving, the brain is receiving information and deciding what to do, that's all based on a prediction in the first place. You've cooked dinner, you're expecting to be hungry, your digestive system is getting really ready to digest that food, and it starts predicting that and already having a response inside your body. If you think about your mouth watering when you smell something really delicious, that's a prediction by your brain. Oh, that food smells really good, I'm going to eat that soon. Start producing saliva. That saliva has special enzymes or chemicals in it to start breaking down the food. So it's already predicting the type of food that's coming and that it's going to need to digest it. And then it responds to the food that you put in and then changes how much of everything is happening based on what actually ends up inside your body. Hopefully some of these examples are resonating with you so you can then make sense of pain in light of just understanding that that's really what we go through every day.
Well, just you talking about food, I think
everyone's hungry.
getting ready. Yep.
Right, we'll finish off with just a couple of other examples. And then if you've got any questions on what we've been through so far, if you can send them through to Fatih as we just go through these last examples, that would be great. So facial expressions, another one that we're all very familiar with. We can tell what someone's thinking a lot of the time without them needing to say anything. The better that we know a person, the more that we can read their facial expression. So if you can think about your ability to read a stranger's facial expression based off a family member or your best friend, you can read their facial expressions much easier because you've had that experience of putting together their expression with their mood a lot more. So you can read it a lot more subtly. And we learn this from when we're very young. If you think about any interaction that you've had with a baby and how they respond to your facial expressions, that's a really important part of survival and thriving. So that's something that we get really early before other forms of communication can really take place. Good. So what we're really saying is the brain constructs what we see, what we hear, what we taste, what we smell, etc., based on what it expects. Other factors are going to affect this also. So our belief, past experience, our worldview, our culture, all of these things affect it. So if we think about past experience really affecting something that gives us a protective response now. So if you picked up what you thought was going to be a pear, oh yeah, sorry, that does make sense. My apologies. I thought for a moment I'd written this backwards. If you eat a slice of apple, but you thought it was going to be a slice of pear, the apple's going to taste bitter. Now that's not because the actual piece of apple tastes bitter, but what your brain has done is gone, ooh, that's not pear. I'll give it a bitter taste because a bitter taste is kind of our taste equivalent of pain. It's a protective response to say, that's not right. Should you be eating it or is it a threat? So then we go, oh, that doesn't taste nice. But then we look at it and we go, ah, okay, it's apple. And then we take a bite again. The apple tastes like apple again. Nothing's changed in that piece of apple, but our brain's prediction was incorrect. And because the prediction was incorrect, and then it thought, oh, we need protection or possibly need protection right now, it gave us the bitter taste. So we'll get that protective feeling until we have enough information to remove the threat. Good. Do we have any questions so far before we move on to try and apply some of those concepts to pain?
Thank you, Amy. Please feel free to write in your comments and questions and I'll read them out to Amy.
So as just while you get in your questions, I've put this picture in here just as a little bit of food for thought about how we actually represent pain. So, and you'll see this over the next couple of slides as I go through it in other pictures that I've chosen. Like here we've got, it says pain, it's all in capitals, it's red and orange, bright colors that are usually, or in this context, it's associated with fire, and that's, you know, obviously, well, that's not only a negative thing. Fire can be a positive thing as well, depending on what the circumstances are. But pain is often represented in this way. So all of that says that pain is bad. As I said on the very first slide about pain, pain is not bad. Pain is our friend. Pain is a protector. It doesn't feel nice. No one's going to deny that. However, it's not a bad thing. We really need it to survive. And these kind of messages, when we keep seeing something represented in this way that says that it's bad, that really changes the way that we think without us really noticing it. So I implore you, when you see pain represented in this way, to have a little chat with yourself and just think, okay, no, I'm not going to subscribe to that. Pain is unpleasant, but it is useful and it's necessary for a healthy life.
So thank you, Amy. I have Davud saying, so far it's been painless.
I'm glad to hear that. Thank you. And I do appreciate a good pun.
And then I've got a couple of questions. So
Great.
when some people seem to say something is going to hurt or they feel pain easily, this is based on their prediction based on past experiences. Is that correct?
That's right. That's right. And we're going to see a couple of different examples coming up. If someone tells you that something is going to hurt, that actually like primes your nervous system for it to hurt. So not necessarily a helpful thing. Sometimes it's required for consent if you're getting procedures or, you know, something done. They can't not tell you, so you don't know what to expect and give you consent, but it actually makes it hurt more.
And one more is, so can we choose types of pain by training the brain to do so?
Excellent question. And we're going to talk more about that as we go.
All right. So
what this all comes down to is, how can we manage pain?
All right. Thank you very much, Amy. I think we can continue.
Good. All right. So here's another picture of headache, pain, like red and nasty, and, you know, really giving us that pain is bad. And you'll see pictures like this used a lot in advertising as well. So worth thinking about. So pain is the brain's opinion as it tries to keep us safe. It's a protector, it's a warning signal, and it's based on the evidence available at that time to say that an area might need to be protected. And as we've said, it does not predict tissue health. So let's have a little chat about the pain process. I'm going to keep this not too in-depth as far as the science goes, but there's some additional resources and links available for you if you would like more, and you can always contact me through Fati if you want even further resources if you're really wanting to learn about these processes. But our pain process, this diagram that's here is a simplified diagram to show when it goes, messages go from the finger and how they come into the spinal cord, which is the round part with the butterfly shape, that's like a cross section of the spinal cord, and get up to the brain. So it's just a diagram to show those main signaling pathways. We're not going to go through that in detail because that is far beyond today's kind of content, and you won't ever, I don't think you'll ever need to kind of know that level of detail again. But again, if you're interested, please learn because it's fascinating. So we've got 4 main things that happen: transduction, transmission, modulation, and perception. So transduction. So this is when we get the generation of a signal. So that's an action potential, is just referring to the electrical signal that runs through the nervous system from a nociceptor. Keep nociceptor in mind. That's one of our little sensors that's out in our joints, in our muscles, in our skin, in all of these areas. so a specific type of receptor. So transduction is that receptor gets activated and it generates an electrical signal. That signal then needs to be passed. So if we use our finger as the example, it needs to be passed from our finger through to our spinal cord. That's the pathway of the nerves. If you can remember that from our other webinars, if you can't and you jump back to those, you'll get that pathway. So it comes from the finger, runs up the nerve, all the way up our arm and comes into our spinal cord. If it's our finger, it's coming into our spinal cord around our neck. And then it goes all the way up and into our brain through the spinal cord. And that's when we reach the central nervous system. So everywhere before the spinal cord, out in our limbs or the rest of our body, that's our peripheral nervous system. And then our central nervous system is our brain and our spinal cord, just as a little bit of a reminder. So we can then modulate the pain. So we'll chat about that a bit more in a moment, but we can either increase or decrease how strong those signals are, depending on whether it seems that the threat is like quite large or if the threat doesn't seem as large. And it's at this stage of perception, once our brain starts to interpret all of this signaling that's gone on, and then thinking back to our initial definition, that we start to add on some emotional factors, that's when we feel pain. So all of these other levels, so when our finger first touches something, all the way up through the nervous system until it gets to the brain and we start to have a thought process and an emotional response, that's when it's actually pain. Up until then, it's the same as with the eyesight. It was light and it was electrical signals, but it's only once your brain gets the information, puts it all together and interprets it, that it actually becomes a vision and we can pay attention to different parts to change it. Exactly the same process for pain. Please let me know through Fatih if I lose you at any stage.
We've still got them all. We've actually got 3 people added since start. So we haven't lost anyone so far. Well done, Amy.
All right, so what is the type of information that our brain receives from our body to make a decision about whether pain is needed or not? So as we've mentioned, our body is constantly sending information to the brain about what's happening in an area. We don't usually know that this is happening. We don't need to pay attention to that. We're too busy paying attention to all the fun stuff in life. So this is just happening in the background. So we get all of our sensory information, so light, sound, everything like that. We get thermal information, so whether things are hot or cold along the whole spectrum. We get mechanical information. Is there pressure on an area? Is an area being stretched? We are aware without realizing it most of the time about where our body is in space. So again, if we want to reach for that glass of water, we have to know where our body is in space and have some kind of perception about where that glass of water is in space so that can happen smoothly. We get lots of chemical information. So that can be, you know, your whole digestive process, inflammation, anything else. So acid responses all throughout our body is another really common one. There's an endless array of those. So all of this is happening in the background. And then one of the final types we get is this process known as nociception. So nociception is when our receptors in any area of our body are processing a noxious stimuli, so something that seems as though it could be dangerous. So these are our danger signals. They're not pain signals, because for it to be pain, remember, that's once we're up in the brain and once we're adding on those extra layers. So when it's just sending information saying like, oh, this seems a bit dangerous, that there's inflammation around, or that there's a bad smell around, or that there's too much pressure on an area and that's seeming as though it actually may start to cause tissue damage. So we'll use that as an example. So if we've got an increasing pressure on an area, to begin with, we just have the receptors saying, yep, okay, something's pushing on that finger, that's fine, that's fine. As it starts to get stronger, then we're aware that it's getting much stronger. But as it starts to reach that point, that it might start to cause some tissue damage. And this happens well before tissue damage occurs as a general rule, unless something happens too fast in, like, say, a traumatic instance. But if we kept pushing there, then we'd start to be like, oh, that's getting to be a lot of pressure. And then we start to get these danger signals being sent up. So all of those receptors, so our nociceptors, they start to increase how much they're firing off these electrical messages. So as we start to get a bombardment of all of these danger signals coming up to our spinal cord and to our brain starts looking at that and being like, oh, really does seem as though there's a threat in that area. And at that stage, it can give us pain as a protective response to make us do something to remove ourselves from that threatening situation. How are we going? Does that make sense?
Still going very well. Yep.
Yep. Good. Just again, please let me know if anything's going a bit too fast or too far.
Well, all makes sense so far, Amy. Thank you.
So our next stage that we have, so there we've looked at transduction and we've spoken about transmission. Then we have pain modulation. So there's two areas that this can happen. If we have a look at this diagram, where it's got the nerves coming up and reaching the spinal cord down the bottom and then into different parts of the brain stem, which is the very lower part of your brain, and in this middle section, and then up into the main part of your brain, or the cerebral cortex is what it's technically called. We have a couple of points in which we can actually modulate pain. And there's a couple of ways in which this can happen. At the spinal cord level, we can increase or decrease those danger signals and that are coming up to the brain, but we can also increase or decrease the signals coming down from the brain to say your finger hurts. That is now painful. Feel pain in your finger. We can, at the spinal cord level, increase or decrease those depending on what the situation is. And there's a whole range of factors that affect that, which we'll go and talk about a little bit further as we go on. The second place in which we can modulate pain is up in the brain. Now, this is the part that I find quite exciting, at least, is we have our own, basically our own drug cabinet in our brain. So from these areas, in the middle, if we look at the diagram, we've got the brain up the top, and then the midbrain, which is just below it, and we have this area called the periaqueductal grey matter, or PAG, it's usually shortened to. In this area, we can actually produce our own opioids. So they're called endogenous opioids because they're made within us. So endogenous means made within. So we can actually produce our own opioids, which can decrease the amount of pain we feel. Serotonin, which is another, what's called a neurotransmitter, which is just a signaling chemical within our nervous system. We can release that from there. And then noradrenaline. So if it's not exactly the opposite of adrenaline, but like for an easy purpose, it's another signaling chemical that has a positive effect on decreasing pain. So that becomes really exciting for when we'll look a little bit later at how we can treat pain, because the way in which we actually release these is through generally doing things that we enjoy, things that are nice for ourselves, and also through exercise. And this is why, especially now, if we have an injury or an illness or whatever, exercise is important for so many different reasons. But in terms of what we're looking at today, it actually releases, if we do enough of it, it doesn't just happen automatically. Usually it's after about half an hour of getting your heart rate up a little bit and keeping moving, we actually start to release all of these kind of drugs that are already within our body that can help to improve pain. So that's a really exciting way of actually being able to control it with something really simple. And then it has all the other positive effects of exercise as well, of course. So we've said that the brain receives all of the information from the area, and it needs to combine it with everything else that is happening at the time. So context is really, really important when it comes to pain. So what's the environment that you're in as it's happening is one of the biggest factors. So if you think about if you're at home versus an unfamiliar place, how you feel when you're tired or hungry or sad compared to if you are happy and energetic, who you're surrounded by, whether you're warm or cold. We know that in all of these circumstances, whatever the kind of the negative feeling is, in this case, pain, if it's if we don't want to be feeling so much of it at the time, as I've said, pain is generally a positive, but if we think about it just in that, like, it doesn't feel nice. If we are at home, we're surrounded by people that we love, we're feeling warm, we're well fed, we're feeling happy, we're far less likely to feel pain in the first place. But then if you do feel it, you tend to be less bothered by it. You might be like, yeah, okay, well, I've injured that area, or I know that's sore, but that's okay. I can deal with it right now. Whereas if we're cold and we're hungry and we're tired, then everything feels awful. And if something hurts, what other times might be just a little bit, suddenly that is, such a painful thing, and we find it really hard to cope with. And that's perfectly normal. It just shows that our brain really is putting everything that's happening to us at any time together to decide on whether protection is needed or not, or whether there's a sense of danger or threat to us. It then needs to combine all of this information with our past experience and our expectations. So overall, if there's more credible evidence of danger than safety, then we will feel pain. It's both as simple and as complicated as that at the same time. All right, so an example, stomach ache. So you've got pain in your abdomen, and there's lots of reasons why that could be. So one of the first things we can consider is, and this will be on a subconscious level, but you can also, of course, start to do this on a conscious level or purposely think about it. What did it mean last time I received similar information, and what's the context that this is occurring in? So, oh yeah, it's right, I haven't eaten since 9 o'clock this morning. Yeah, kind of makes sense that my tummy's a bit sore. Or I ate that thing earlier that I thought didn't taste so good, but I just went with it and now my stomach's sore. Heartache, stress and worry. Been through, I'm sure a lot of people here have had their heart broken before, and you feel it physically. So you feel it physically in your stomach, you feel it physically in your chest, hence why it's called heartache. Nothing's wrong with your chest or your stomach. That is your brain having such a big response that you're physically feeling pain. So if we have this circumstance, have a think about if you've had, I think most people would have had a sore stomach in the past. Have a think about, or you can use any other example really, how has the pain been changed by another change in the context that you're in? So say you have been through that breakup and you're really upset, but then a friend comes to visit you. Usually you might stop that physical pain quite a bit. Nothing's actually changed in your body physically, but your brain has had a bit of different context put to it. Something that makes you feel safer has happened, and therefore you feel less pain. If you have, if you've had a stomach ache or a pain in any other area, if you put on a song that you like, something that reminds you of a happy time, or is a bit upbeat and makes you feel a bit positive, your pain's probably going to decrease. So the great thing about the more that we consider these is when it comes to treating people for pain, if we can't take away the cause of the pain, we can use all of these to our advantage to actually change the context, change the way our brain is interpreting our whole sense of danger or safety, and have an impact on pain from there. So it's all different regions of our brain that are involved in this processing. I'm not going to go through all of these, but I've included some slides here for your reference if you are interested, so you can really have a look and see all the different areas that are involved. So we'll just skip through those. So we have some different types of pain. So we can have nociceptive pain. So that's when those danger sensors are being really activated and sending lots and lots of messages back to your brain. Your brain's interpreting that and going, oh, that seems like a lot of danger, feel some pain, do something to protect that area. Nociplastic pain, this will become a little bit clearer when we talk about chronic pain in a little bit, but this is pain that comes from there being altered signaling from those sensors, but they're not actually being any tissue damage that's occurred. So they're sending all of these danger signals even though there's actually no threat around. That's when people end up in chronic pain. Neuropathic pain is when the actual nervous system has a condition or a disease. And radicular pain we've spoken about already, that's when the nerves that come out of our spine are irritated. So that might be from a disc bulge as an example we've used. So our pain can be turned up or down by anything that says there's more or less danger present. So physical factors, psychological factors, and social factors. We said before how that if you're told that something's going to be painful, you're far more likely to feel pain. Red and green lights are a really simple one that's been investigated. If you are given a cold response, so something that's cold but not cold enough to cause tissue damage, if a red light is shown at the same time, you're actually significantly more likely to feel pain than if a green light is shown at the same time. And that's because we associate red with stop, danger, all of those things. So again, it like primes our nervous system to go, oh, might be danger around. And now there's this cold stimulus, better feel some pain, just so you check out what's going on in that area and protect it if you need to. Sometimes our brain interprets the information it receives incorrectly. So that's a minor example of this, but we've got some stories here that really show how much context is everything when it comes to pain. So on a first man, he's on a construction site, he's alone. He shoots a nail through his hand. So it's through his hand, it's come out the other side, but it's still in there. There's no one there to help him. So he drives himself to the hospital. He reports himself that he was very aware that the nail was through his hand and that was a bad thing, but he wasn't feeling any pain. But once he got to the hospital and he started speaking to people about it there, he started feeling extreme pain. That's because when he first injured himself, it was more important for him to drive himself to the hospital than it was for him to feel pain. Whereas man number two, and I always feel a little bit sorry for this man, he's always referred to as a man from the UK. He is on a construction site with his co-workers. He steps on a nail, he sees it come up through his boot, and he's in extreme pain. Someone else drives him to the hospital. He gets there, they give him medications, they're not working. Then they go, all right, we're going to have to cut your boot off then. We've just got to get this out. They take off his boot and they find that the nail had gone directly between his two toes. It hadn't pierced anything. And he's, you know, screaming, well, maybe not screaming in pain, but he's in this immense pain. It's all about that context there. Like at that stage, he really thought that his foot must be injured because the nail's gone through, and he felt that pain even though there was no tissue damage. So it's a really, as hopefully this is becoming really noticeable for you, it's all about protection, how much danger and safety there is, and what you need to do to get yourself to a safe place. If it's not helpful to feel pain at that moment because you need to achieve something to get to safety, then you're far less likely to feel any pain. And I'm sure lots of you, like we've heard lots of stories about similar circumstances where people have done amazing things, or you just think, how are they doing that with a broken leg, with, you know, an injured arm, whatever it may be. So we can have pain without tissue damage and tissue damage without pain. So if you've got any examples here that you'd like to share, or that you now, as you're listening to this, you're starting to think, oh, that's really interesting. So we can have, if you ever think about if you've gotten a paper cut and then you like don't know it's there, but as soon as you look at that, you think, oh my gosh, that is so sore. And because they usually occur on our fingers, we really want to protect our hands. Our hands are interacting with our environment all of the time. So we're at a lot of risk of getting an infection or getting injured. So we start to pay a lot of attention to it then, and we feel pain because our brain is saying, protect that area. I'm sure we've all had some bruises and thought, well, I don't know where that came from. I don't remember doing anything. Your brain didn't think that it was in enough danger to provide you with pain. But again, once you see that bruise or you poke it a little bit, you're like, oh, no, that is sore. Nothing's changed at the bruise. That was already there from the day before or whatever it may be. But it's just that context and that you're putting emotion on top of it. We've spoken about arthritis in the past. Those changes that occur in the bones and the joints, that happens well before we get any symptoms, because the brain's looking at the information from the area and thinking, oh, okay, well, that's changing, but that's okay. It's just once we reach that point of it feeling like it's a threat that the brain starts to give us pain there. Stress headache is another one you can probably all relate to. Again, similar to that stomach ache from other reasons, or maybe from stress. That's another instance of it being a physical pain that's not due to tissue injury. And low back pain, I imagine there's a few people with low back pain in here that are finding this all very interesting. But if we have a look at these statistics here, and we spoke about disc bulges, so to bring it back to some things we've spoken about, when you're in your 20s, here we've got a 37% chance of some disc degeneration happening in people without symptoms. When you're in your 80s, even if you have no back pain, there's still a 96% chance that underneath that, you've got disc degeneration happening. So it's, again, just really proving that it's all about context and that sense of danger.
I've got a comment here.
Yep.
Rabia, I have had severe neck and back pain and all results came out to be okay. Turned out to be caused by stress and anxiety.
Yep, perfect example. Perfect example. And we're going to talk about how that comes into some common treatments for pain that will relate into that.
Yeah, and I broke a finger last year playing soccer, and then every week I go to play soccer, like during that day, I'll start knocking it around and it'll start hurting, but any other day it's fine. But actually on the Monday, I'll be like, oh, that hurts. Oh, why does my finger feel funny today? And now that you mention it, it's just my body's way of, I think, just warning me, saying, don't break it again, you got soccer tonight.
Yeah, exactly. And I mean, all of this is not to say that when you do have an injury or a condition occurring or damage, or there is tissue damage, of course, there's a good chance that you'll feel pain in those circumstances. It's not to deny that. It's just kind of understanding what the pain actually means. So you can have, a lot of tissue damage with a minimal amount of pain, or no tissue damage with a lot of pain. It's just about making sure that we understand really what it means, and that pain is a protector, and pain does not represent how injured or how damaged we are, or any of these kind of really negative words that can come along with it.
I've got another comment from Shada.
Yes, great.
I had an accident in my Vespa scooter. I passed out for a few seconds, got up, came home on my scooter because I had visitors for dinner. After we had finished, the pain was severe. I called the ambulance and then stayed in hospital for 4 days.
Oh, wow, you must be I don't know who your visitors were, but you were a reliable host.
Well, I can say, looking at that name, I think Shada is Turkish, and with us, I think going to the hospital comes after serving your visitors, right?
Yeah. That's very impressive and a good example, a great example.
It's yes, Shada says definitely. I can vouch for that too. I mean, I came off my scooter a couple of years ago and everything was fine for the first couple of days, and I was like, oh wow, you know, I can't believe that I'm actually feeling this good. And then a couple of days later, and it was after the fact that everyone around me was saying, are you sure you're okay? Are you sure you're okay? Are you sure you're okay? And then I started going, oh, maybe I'm not okay. You know, maybe my shoulder does hurt a bit. And then, you know, I started feeling pain after that.
Yeah, and it's a good reminder that we should be mindful of where we can, and especially for me from a healthcare practitioner's point of view, is mindful of the language that we use with people and having that consideration of if you can unwittingly and with the best of intentions change how someone feels in these ways that we don't recognize. So hopefully today's webinar will actually help you have a bit more of an understanding about that. Yeah. Phantom limb pain is a really interesting one. So this can occur following amputation, where the person will say, like say if they've had an amputation from the elbow downwards, they will swear that they can still feel their forearm and hand and they feel pain in it. So that pain is essentially the brain still looking at that area and being like, it feels like that's in so much danger, which obviously it was, and still giving that sensation of pain. We're just going to do a quick recap of a couple of areas that we spoke about previously. So we spoke about our somatosensory cortex. So this is the area of our brain that you see here in the diagram, in the kind of greenish area. And I couldn't think of the word for the color green then, which is interesting, in the green area. And that's where all of the information from all of our sensory receptors and organs around our body sends all that information back to the brain. There and a bunch of other areas, that is like our main area for receiving that information. And then we also spoke about the homunculus. So this is where we have this map of the body along that strip of the brain. And then we can see how it's represented here along there. And if we look at so that on the left, the somatosensory strip, we can see that the areas where we have a lot of sensation, like in our mouth, our face, our hand, they have a big area of the brain that's given to them. So what that means is if someone's had that limb amputated, so if we think about the hand area, all that area of the brain that's dedicated to receiving signals from the hand, all of a sudden that's massively changed. So the signals that they're getting from that area have essentially disappeared. And from the area where the amputation have occurred, those signals in that area have massively changed at that point. So it's getting all of these odd signals and thinking, oh, this just seems so threatening. So you feel pain in that area. Even though consciously we're aware that that's been amputated, when we just look at this really local part of the brain, those nerves in that area, without adding on the context of everything that's happened, those nerves in that area don't realize that. So they keep on trying to send out all of these signals saying pain. So over time, as everything adjusts, that for most people will go away. Some people unfortunately have it for a long time or forever, but for most people it will diminish. Now here's the really interesting part. In some people, when they've had that amputation, if you were to stroke their chin, they'll actually feel that and go, I feel that as though I still got my hand. So what's happened there? Because our brain it's tricky, but it's smart. It starts to look and it's like, well, I've got all of these nerve cells. I've got all of this area of my brain that now doesn't have a hand to look after. I'm not going to let that go to waste. Because the chin area lies next to the fingers and the hand here, it starts to increase the amount of the brain that's designated to the mouth and the chin area. So when you touch that area, until that mapping has all changed, then they'll feel it in their hand. So we're going to come on and just talk a little bit about how the brain changes and about how we learn next to show how that actually occurs. But hopefully you find that as interesting as I do. Quick recap. Pain's a protector, doesn't predict tissue health. It's a warning signal from our brain. You can have pain without tissue damage and tissue damage without pain. And pain is turned up or down by anything that says that more or less danger is present. So chronic pain is pain that lasts more than 3 months or past the time when the tissues have healed. If there has been an injury to the tissues, the actual, the muscle has healed, the joint has healed, you had a virus that was affecting your stomach, that's gone, or whatever it may be, but we still get pain. And this is 1 in 5 Australians are affected by this. So that if they're over 45 years old. In 2016, so that's kind of a bit, the data is getting a little bit older, but there's been some hold up in collecting new data because of everything that's happened in the last 12 months. 1.5 million people. So it's a really major thing. So I'm sure that you're interpreting for quite a few people that are in chronic pain. The interesting thing about chronic pain is it's actually a learned process. So we have to learn to feel that chronic pain. It doesn't mean that the pain isn't real. It doesn't mean that it is very unpleasant. It is perfectly real. It's not made up, but it has been a learned response. So we used to think for a very long time that the brain didn't change, but we know now that that is just not true, or it didn't change once you'd reached, maturity, once you'd finished growing. That's not it. Our brain is changing all the way throughout our life. We see this really easily every time we learn a new task or information. Every time that happens, we're creating a new pathway between the nerves. And we strengthen this pathway by repeated use. So if you drove a truck through the bush and you create a new track, the more that you drive over that same area, that track is going to get more and more ingrained. And that's exactly what we see within the nervous system. And if you think about, if you hear a piece of information once, unless that piece of information, if the piece of information is really important or has a really strong emotional reason for you to remember it quickly, you'll remember it. But if it doesn't really have that, then we probably need to hear the information a few times to really cement it. So again, repeated use. So some of you may have heard of Pavlov and his dogs, and this is just essentially to show a really early example of how we learn a response. So Pavlov, he had his dogs and he started, he noticed, not noticed, everyone knows this as we spoke about earlier. If you smell food, start to salivate. So what he started doing is every time he gave the dog food, just before it, he'd ring a bell, or at about the same time. So rang the bell, gave them food. So what they started to do was to associate the bell with food. And then once you just rang the bell without the food, they'd still salivate. So they learned that the bell had something to do with digestion, and that was their body's automatic subconscious response to start to give that. So you can look more into him if you want examples, but that's just a really nice, simple way of showing how we can start to associate two things with each other that we previously didn't, and then have this learned subconscious response to it. So how does this apply to pain? So the pain signaling pathway undergoes changes. So those nerves that carry the signals, those nociceptive signals or danger signals to the brain, or the brain itself are affected. So the nerves might become more sensitive, or the brain might actually start to misread the signals. And as it misreads the signals and gives an interpretation that isn't as accurate, so it starts to look at the signals and think, oh, yep, danger, 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 then it's going to keep giving us the sensation of pain. Instead of looking at the signals and thinking, no, it doesn't seem like too much danger, that's okay at the moment, it's very ready to give us the feeling of pain. And we also start to see that we can have those modulatory effects that we spoke about, and particularly those ones where we have that drug cabinet ourselves and we can release those kind of medications in our own body. We start to see less of that, unfortunately, as well. So it really affects the whole pathway, all the way from in the periphery all the way up to the brain. The whole pathway is affected. If we have a look at who develops chronic pain, more likely with age, more likely in females. And then there's a few things that can happen. So if someone has that really strong emotional response to pain, then they're more likely that that will turn into an ongoing persistent pain. So like I said, if we hear a piece of information and we have a strong emotional response to it, we're much more likely to remember that piece of information. Same thing with pain. Someone has what we call fear avoidance behaviors. So they think, oh, my back is sore, I'm not going to move. It's sore and therefore it's damaged and I'm in a lot of pain, therefore there must be a lot of damage, which we know after today is just not true. Pain and tissue damage do not relate to each other in that way. And then if they think, oh, I really need to avoid moving, I need to avoid doing this, I need to avoid doing that, they're more likely to get some ongoing pain. And then if you have comorbidities, and particularly mental health, as we spoke about earlier, you know, when you've got other things going on and seeing as pain is all about your brain's interpretation of what's going on. If you have some mental health issues at the same time, then, you know, the interpretation of what's going on as far as pain goes is more likely not to be as accurate and then develop into chronic pain. Gets more complicated than that, but as a simplified way of looking at it. So as we continue to connect pain with different stimuli, we feel it more and more. As far as what these stimuli can be, this can be all of that messaging in our nervous system that we're not aware of that's happening below our levels of consciousness. We may start to think, every time I exercise, every time I bend my back, every time I lunge down and get something and put that pressure on my knee, that's when I get the pain. So then we start to associate that movement with pain, and like the bell and the food, we start to associate those things together and we learn that response. So anything that gets associated with the pain can have this effect. The list is literally endless. So in these circumstances, if we think about this, how can we recover from ongoing pain if that system does get the signaling and the interpretation, all of that does become ineffective? So we can unlearn these changes. So we've probably all gotten out of bad habits. I used to bite my nails like crazy. That's a common one, but I'm sure, you know, lots of people have had different habits that they've done. Or if you've changed your thinking about something, maybe for some of you changing your thinking about pain today and how it works, this could be a good example. You're creating new pathways in your brain, and as you start to do that and you solidify these new pathways through repetition, what happens is we have this use it or lose it rule. So you start creating new pathways and you're not using the old ones anymore because you don't have that habit or you're not thinking about it in that way. All of those nerve pathways, because you're not using them, they diminish and they can actually become like completely gone. So that's why we call it the use it or lose it rule. And we see this both physically in the actual physical pathways and also functionally. We've spoken about functional MRIs in the past where we can see what's happening throughout different parts of the body. We have other types of imaging and electrical, like nerve conduction studies that we've looked at in the past. You can use all of those and really have a look at that, those pathways and how they're working and when they're getting stimulated. This, you know, that's all well and good. Just unlearn the changes. It's a lot more complicated than that. It's a very difficult process for someone who's got chronic pain, because the longer that it's been present, the stronger those connections are and the more influences there are on their pain. So that really needs to be taken into account. And this is a diagram that I absolutely love, and I show it to patients all the time. So we want our recovery we expect it to be a nice straight line of improvement. In reality, it is up and down and every other direction, sometimes all at once. But overall, we keep pushing forward, and when we do get that improvement. So that's a nice way of thinking about recovery from anything, really. So we're just going to finish up with a little bit of about treatment of pain. Now, there's so many different options for this. Number one, if there's an underlying or associated condition that's, just sending all of these signals up to the brain that's making it sense danger and then make you feel pain, let's treat that. That's a good starting point. We can have our pain management medications. We have some interventional procedures, which we'll touch on, and then we're going to recap the biopsychosocial model, which we have mentioned in, I think, the first webinar was. So treat the underlying conditions or associated conditions. If it's musculoskeletal, which is, of course, my area, then getting some manual therapy, doing your exercise rehabilitation, make the area strong, make it mobile, make it function well, so we're getting less of those danger signals going up, the area feels safe, and then hopefully we stop feeling pain. If it's gastrointestinal, then, don't remove the foods that are causing upset. If it's medications causing your stomach pain, then remove those, whatever it may be. We may have to do a surgical repair. There's so many options depending on the system that you're talking about. We have pain medications, which I'm sure you're familiar with a few of these. So things like your paracetamols, your anti-inflammatory medications, opioids, and then we have these medications called anti-neuropathics. So they say neuro in it, so they work on the nervous system. Pathic, so representing, remember, pathology, meaning disease. So they work against nervous system disease. So essentially they work on the nervous system to try and all those pain pathways that we've been talking about, they work along those to try and help decrease the amount of pain you feel.
Amy?
Yes.
Just going back on the previous slide, can you give us, because we hear a lot of these medication names throughout our interpreting sessions, can you just give a few examples? Look, I know that paracetamol, we've all heard and probably used Panadol, Panamax, along those lines. Can you give us some, just a few, I know we're not trying to advertise any drugs here, but just a few names of some of these drugs so that we know what they are when we do interpret them?
Yeah, so anti-inflammatories could be things like your Nurofen, Voltaren are the brand name, probably two of the most common brand names that you'll see. And then these are for non-steroidal, so you might see that shortened to NSAIDs, and that's they're kind of all based on like ibuprofen. There's another area of non-steroidal anti-inflammatories. You might have heard of Celebrex or Mobic, and they're some different ones based on the pathways that they work through. The steroidal anti-inflammatories are like your corticosteroids, so prednisolone, cortisone. Those are probably the most common ones.
Very good.
Opioids are going to be your like methadone.
Is oxycontin an opioid?
Yes, that is. And what's the one you're often given after surgery?
NDEP, is that an opioid?
Yep, NDEP is that's technically that's technically a synthetic opioid, but it is indeed.
But yeah, we hear these a lot during interpreting sessions.
Yeah, and that's probably something that maybe we can look at a list.
Yeah, let's make a medication list and we'll send it out to our interpreters too. And the anti-neuropathics, is Lyrica one of those? We hear that a lot as well.
Yes, it is. Yeah. Lyrica is. Amitriptyline is another one. If you hear anything that says like triptan in it, that's going to be one of those. So they're often medications that are also used for anxiety and depression. and yeah, those types of areas. And that just means that they're, because those mental health problems are treated by targeting the nervous system, you get that crossover where they can be used for different reasons.
Thank you.
Cool, not a problem. So the biopsychosocial model, we've touched on this slightly in another one, but hopefully you're really seeing that because pain is influenced by so many different factors, and especially that it's in that interpretation realm, it's not just enough to address the physical components a lot of the time. The example that we were given before, which I'm so sorry I've forgotten your name, of the person who had back pain that turned out that it was caused by stress. That means that you can have, if we think about pain in this circumstance for what we're talking about, usually we talk about health or well-being being this middle part in the Venn diagram on the right here. We usually think about that middle part where everything crosses over as being our point of well-being. But for the purpose of today, if we think about that crossover part in the middle as being pain, it can be affected by all of these. For some people, the biological factors will be the real driving force behind it, and the psychological and social factors have a much lower impact on it. For other people, they might have very few biological factors, but say like socially they're very isolated or lost their job or something like that is going on, and that's really driving that physical sense of pain in an area. Or we could have these psychological considerations as well, and that really also comes into our beliefs and our expectations. And that's what I'm really hoping from today. This is such an important part to take away from it, is that pain is not just as simple as the biology, and that if we want to be really effective at treating pain, at helping others with pain, at understanding our own pain, then we need to recognize that all of these different areas play into it, and that you have to really, for the individual person, it has to be considered how much they contribute. And if today I can have helped in this area of beliefs and expectations, as in your understanding of pain and your beliefs around it, then I will be very happy, because this is a big passion of mine. And it's just such an important thing to understand and to reflect back on for yourself and for others, and hopefully can really help your interpreting as well. A lot of people, when they, sorry, I'll finish off with the interventions in a second, but a lot of people, when they've had pain for a while, pain becomes a big part of them. It's a really big factor in their life, and they're holding on to their pain because especially if they don't understand it well. And when we go through pain education, which is a really important part of helping someone understand what's going on in their body, whether it's acute pain or chronic pain or whatever it is, understanding it, as I said, takes away the fear. If you've been holding on to your beliefs about pain quite strongly, and I've started telling you all of this out of nowhere, you'd think I was crazy and I was devaluing your experience, and that I'm telling you that the pain's all in your head, and that's not at all what it means. So I think if you can understand this more yourself, and then if you hear someone talking about it, you'll be like, I've heard this before, and think back to all of these examples that we've been through, then yeah, hopefully it will really, really help you from there. So rest of our interventions for pain. So we can do a denervation, or there's some other names for it, where we actually affect the pathway. So that pathway is just sending too many signals, and this is usually done more in the periphery. So let's actually just remove that pathway. So obviously that's, we're getting into some extreme interventions here. So a lot of other things will be tried beforehand. We can try and block the nerve signaling with anesthetic. That can be done in a few different ways. The injections are common, or those steroidal anti-inflammatory injections, which we've mentioned before. Botox is another one that can be used, Botox injections into an area. We might get as far as actually doing something like a joint replacement, so that, you know, all of that, if we think back to our joint structure, in hip and knee are really common ones, all of those nerves that are attached into that area are just firing off so many signals, and the brain just keeps looking at it like it's a threat. And then do a joint replacement, and often, usually, that pain goes away because we've had that change in the signaling coming up to the brain, and then the brain manages to adapt and start to look at the area, and over a bit of time starts to go, oh no, that doesn't seem like a threat now. Good, got a new knee in there, beautiful, let's not feel so much pain. So that can be usually really successful. Then ketamine is another drug that's an anesthetic drug, and you can do infusions of that. And then neuromodulation is a relatively newer area, and that's where they actually put a little stimulator, usually around the spine, and it actually sends off its own electrical signals to interfere with the signaling pathway. So that's a really exciting area, and for those that it works for, really successful and life-changing, which is great. So that was what I had for you today. Do we have any other questions?
Thank you very much, Amy. I really appreciate your time today. Very, very well prepared indeed. I've got a question here from Maria. What about biologic therapies? Are they good enough to reduce inflammation?
So they're often used for inflammatory conditions and autoimmune conditions. So some of them that we spoke about last time, like rheumatoid arthritis and things like that. And that just, I guess the effect that they will have on pain depends on how much the inflammation or the immune response is driving your pain. So if we think back to that biopsychosocial model, depending on how much those biological factors are actually driving your pain will depend on how much of an effect that they have. And that comes down to the individual.
I've got another question. What category does the combination of paracetamol and codeine fit into?
So it comes, mixed medications still technically come under both categories. So codeine is technically
or something.
Sorry? Yeah, that's like your Panadine forts and those types of medications. Yeah, so they're just a mixed medication. They don't get their own kind of category from there.
Amy, I interpreted a couple of years ago for a lovely young gentleman for 2 weeks straight, every day at a clinic in Frankston, and it was called a pain clinic.
Yes.
And it was a whole day. For me, it was a life-changing experience in regards to interpreting. I was there from 9 till 5 every day for 2 weeks, like a full-time job, Monday to Friday. We went in there. I mean, I'll tell a little bit about what happens in there, but can you tell us, because I know that some interpreters, if not all of us here tonight, will have had some kind of work in a pain clinic. Yeah. Can you tell us what's involved after going through the biopsychosocial model as well? You know, it just reminded me.
Excellent, yeah, excellent question, and something that I had actually planned on putting in here, but yes, didn't. So I'm very glad that you asked it. So pain clinics are great. So when we think about this biopsychosocial model, what this really, what it represents is that we need to get our best response, and this is particularly in chronic pain, because in acute pain, mostly as the tissue heals, the pain will go away. And it's still important that people understand what acute pain means and have all this information, because that's part of the way that we stop it from becoming chronic, by taking away the fear, by getting them doing having a good management program that stops it becoming chronic. But when it is settled into that kind of that chronic phase, and we're thinking about it from biopsychosocial, we really need a multidisciplinary team. So it's called working around the person. So we need someone thinking about or multiple people maybe crossing over in different areas, thinking about these biological factors. So addressing all of that with medications or rehabilitation or whatever it may be. We need people thinking about their mental health. We need people educating them about pain and changing those beliefs and expectations. We need to think about what is their support network? How can we increase that? What services do they have access to? And pain clinics are trying to bring all of that together for us in the one place, because it can be, if you imagine that you need all of those different things addressed, that can become overwhelming. It can really use up a lot of your resources very quickly, as far as time, finances, even just the energy, like physically and emotionally spent on going to all these different appointments and maybe getting different information from different people, different opinions, whatever it is.
And even scheduling yourself, it becomes a full-time job managing
Exactly.
your pain, going from
That's it.
one to another professional.
Yeah. And instead what we want to do is we want to streamline that and give the person room to engage with life, and to engage with life in a positive way. So then their overall sense of safety and well-being can improve. And then hopefully that comes along with some decreases in pain. So the pain clinics are a really good way of getting that multidisciplinary team around someone in the one place, seeing different practitioners who are on the same page, who have an interest in pain, who know all of this information that is up to date and relevant for what we understand about pain now, and not thinking about it in the older ways. So they get really good, what we call patient-centered care. So it's all about what that patient needs. So yeah, and as you said, I'm sure, yeah, you'd learn a lot from going there.
Yeah, I mean, there was, like you said, multiple disciplines. I'll just quickly go through the day for those who haven't been there, but you know, just so that we know what to expect. The day started with, it was like a classroom. There was about 10 people or so in there, and then first there was a session. It could be sometimes from a physiotherapist, sometimes by a doctor, sometimes by a psychologist as well. You know, there'd be basically a class given for a couple of hours, and then there'd be a lunch break, and then there'll be physio, one-on-one group sessions, and then if they are in the afternoon, there was a one-on-one with a psychiatrist. And you know, this went on for 2 weeks, and I was interpreting for a physiotherapist, a occupational therapist, a psychiatrist, a medical doctor, all at the same time within a day. So I think it was really important. I wish I did this webinar before that, to be honest with you. And it would be really useful to know and understand pain, to be then able to interpret pain, because it's all about having that knowledge of the content and just anticipating what might be coming next. And I think that really helps. The knowledge really comes in when we're interpreting in these settings, and having the knowledge of the content, the terminology, you know, where's this person coming from? What's it going to? I think that's when it all comes together, and then we go, oh, I understand why we're doing these kind of webinars, because then it all makes sense once all the disciplines come together, all the knowledge comes together. You're able to use your terminology, the knowledge, anticipate what's going to be said next, because sometimes you have to do consecutive interpreting, sometimes you have to do simultaneous interpreting. And I think just having this knowledge is really going to help us with that. So thanks very much.
Excellent. That's what I was really hoping. So we spoke about these, and I guess muscular system and the skeletal system are kind of obvious ones for me in my work, but this is an area that I'm really passionate in, and I think that the more that everybody understands more about it, and as the message gets passed along, so if that's you leaving today and finding this really interesting and telling some of your friends or family, and then the word kind of spreads to really change our perception of pain, I think that that can only be a really positive thing for everybody. So you can probably tell I, am a bit of a nerd about this stuff. So it's nice to be able to pass it along.
Thank you very much. We can really tell that you actually not only are very good at it, but also you enjoy this. That really comes across. Thank you very much. Question, is meditation an effective tool to combat chronic pain?
Yeah, great one. Yep. So meditation is meditation we give to a lot of people. It's a really nice way of, earlier when we spoke about the autonomic nervous system and we spoke about that fight and flight or rest and digest. So that rest and digest, nice calming, safe feeling, meditation really helps to kind of stimulate that area of the nervous system. And it's a nice way of kind of, whether you're in pain or not, it's a good way of kind of resting within your body without passing judgment. That's, you know, generally the idea of meditation, is that you can't stop yourself from having thoughts. If you're really fighting against, I don't want to think about anything, then you're spending all your energy thinking, I don't want to think about anything, and that doesn't get you very far. So the idea is that you learn to sit with your thoughts and feelings just happening as they happen, but you don't pay them any judgment. On a simple level, that's what we're aiming for. So it's really, really helpful.
Thank you, Amy. Now, some of you have pointed out that the glossary document is not downloading. I do apologize. I don't know why it isn't. But we will be emailing you with all the handouts tomorrow as well. So those of you that weren't able to download anything tonight or you couldn't download that particular document, we'll actually email you with all the handouts tomorrow with the link to the recording as well. All right, so rest assured that you will get it. And I think Amy's going to do another list of a little list of medications and categories. So those of you that registered today, we'll make sure that we'll email those out to you as well. All right, so thank you very much. I think we've answered all the questions tonight. Amy, thank you so much again for your time and your presentation. And also thank you so much for the last 2 webinars as well. Over the last, I think, over the last 6 weeks, every 2 weeks, we've been having the pleasure of you presenting us with your very well prepared webinars. So thanks very much. We do really appreciate your time, and we look forward to welcoming you again in the future. And I'm sure
thank
that
you for having me.
you are so excited about your profession, and it really does come across. And we look forward to having you on again. Now, those of you that have been tagging along for the last 2 webinars, this is the end of this particular series with Dr. Amy Lawton. Those of you that missed out on the previous ones, you can go onto our website. The series was called Healthcare Specialty Series, Introduction to Musculoskeletal System. So in the first week, Amy presented about the skeletal system. The second week was the muscular system. And the third week tonight, we had the nervous system and understanding pain. All right, so if you want to put them all together, you can do so. Those of you that missed out on the previous webinars, they are available on our website, conversations-interpretingtranslating.com.au. So you can get there and get access to those videos as well. So please keep an eye out on our website for more training and PD opportunities. And I thank you all so much for your attendance today. I know that after a hard working day, just when we're all supposed to be having dinner, you take the time to enhance yourself and advance your interpreting skills. So I do really appreciate you taking the time and joining us today. So please have a look at our website for more PD opportunities and training opportunities. As some of you might know, that we also offer self-paced online courses and modules, as well as live webinars like this. So please click onto the website and see what's coming your way. Again, Amy, thank you so much. You have been amazing, and hopefully we'll see you again in the future.
Lovely. Thank you, Ian.
And thank you again, everyone at home, and we'll see you in the next one. All the best.